So we are now recording, so everybody is aware. So what we're going to do is we're going to go over schizophrenia. We're going to go over, of course, in depth about the brain, of what's going on. However, I do want to remind everyone that we are not leaving this class psychiatrists. We're not leaving even as mental health nurses. The point of this class and the reason that we're all here is to get a much better understanding of what's going on, not just physiologically and in the brain, the body. It's usually in the brain when it's mental health, but I mean, of course, the body can be affected as well. And we'll talk about that when that's applicable. But it's not to leave here the master of psychology and psychiatry, right? That's not our role. That's like taking a pharmacology class and you're taking it from a pharmacologist and you leave knowing every single thing there ever is to know about a medication. No, that's not what I'm doing. What I want to do is teach you, for example, and this is just an example, for example, and you do not have to write this down. This is just an example. But later on, we will talk about 4 specific medications, 2 what I call old school antipsychotics and 2 newer antipsychotics. And the reason I'm mentioning 2, we will talk about more during, like I said, every week we build. So right now, like today for our quiz prep, we talk about, there's about 8 terms. We're going to talk about them and we just build and build and build and build. And we keep going over them and over them and over them. Every week I have them on Quizlet. Again, today we're not using Quizlet. Same thing with medications. So that when you're in clinical and you're reading a chart and you're like, oh my God, I actually recognize that medication, or, oh, you can use that for that. Oh, that's right. You can use an antipsychotic, certain ones for sleep. So I'm going to give you that example right now. Seroquel, for example. This is just kind of an example of something that you might learn and you're going to learn at the very end of our lecture. So that is an older antipsychotic. So learning the terms, and I always do it the same way. And sorry, I always use my hands because there is evidence that shows if you use your body language and you look at me doing it, it actually will help you retain the information. So I will ask you, what is the classification of Seroquel? And then you guys would say antipsychotic. Then I would say, can it be used for something else? And I will usually say off label, but that's a question I'm going to ask you about later. So we're not going to go there yet. And you will say yes. And then maybe Katie will say, and sorry, let me move my screen so I'm not just picking on the same people. Then John will say, yes, it can be used off label for sleep. Absolutely correct. Excellent job. What could be a potential side effect? And there can be how many side effects to one medication? 50, 100. It always goes from, oh, mild to severe headache, death, right? We're not going to teach our patients that. We're going to teach them what is the most pertinent so that they know what to look out for. And we don't want to scare our patients either. So we learn as we go what is important to teach our patients, what is the most prominent, and what is the most dangerous. So if this happens, for example, if you start a medication such as Prozac, which is the classification as an antidepressant, specifically, it's an SSRI. We'll talk about that next week. But one of the unfortunate things that could happen, and it is one of the black box warnings, is it can cause you to be suicidal. So yes, I want to let my patient know that if this does happen, of course, I'm going to want them not to continue taking the medication, call right away, or if you stop or break out in a rash or something like that. Okay, so I'm going to leave it there and now we're going to start. Are we ready? And then we will take a break. It's 2:04. So was it Katie? Are you you're my, if I get off track, right?
Yes.
Okay. Would you be so kind, or anybody who notices? So we started class at 1:30, take a break at 2:30. Is that cool with everyone? Okay. All right, cool. All right, so let's get started. So again, we're going to do quiz prep, review some terms. You'll get a break. If we have time for the 8-minute video, I think a good video, along with, if you've watched the videos that I've already posted about, and when you do watch them, so one is somebody that's, and it's one that I've never used. They took down the one that I usually use, which kind of sucks, but it is what it is. It's a simulation of somebody kind of going through having a psychotic episode, or somebody who is experiencing a schizophrenic episode. And then it shows somebody during a TED talk who has schizophrenia as well, but is medicated and functional. And I think that is, again, there's a method to the madness of why I try to connect things the way I do. And connection to me is everything, because if you know the brain, then you know the behavior, and everything comes together, and then you remember it. It's amazing. Just wait. I say this every first class, and then by the end, people are like, you were right, Amanda. And I'm like, or not maybe everybody, but the people that say it. Okay. So we are going to start with, first and foremost, any questions about therapeutic communication. We did that last week. I think it's pretty straightforward. We'll continue with it. I just want you to remember, if anything, and this is not on your quiz for this week, but it is purposeful. It is purposeful. And not every single therapeutic, this is just, I want to make sure you all understand this. Not every therapeutic communication has to be open-ended. I know now, if that was on a quiz or a test from another instructor, what is usually done, yes, of course. But can every single question be open-ended? Sometimes I really want to know, like, are you suicidal? Yes or no? I need to know that, right? That's yes or no. So I want to make that known. We try to make it open-ended. Why do we try to make our questions open-ended? To those who are potentially suffering, hearing voices, don't want to be here. I mean, we've all, whether it's circumstantial depression, anxiety, or it's an actual diagnosis, why do we like open-ended questions?
I feel like it lets them share exactly what they want to share.
You're absolutely right. What they want to share, it's not so, in my experience, it's not usually as intimidating. And we don't want our patients to feel like they're being interrogated, right? How'd you sleep? How'd you eat? How was your breakfast? Did you have any bowel movements? Are you hearing voices? It's very dry. It can become very, and imagine if you're paranoid. So when you do the paper roll thing to your ear, if you hopefully do that, or just even imagine, you're living your life and then all of a sudden you're hearing voices. How scary is that? Imagine you as that person. That could be, I mean, I hope it never is, but that could be you. That could be you. You don't know, because as we're gonna, after we do our quiz prep, we'll take the break and then we'll actually get into the lecture's not very long. Honestly, schizophrenia is very black and white. That's why I think it's really the easiest to explain. I do believe it's, other than, well, actually, I think, no, it's not the hardest to deal with, unless they're violent, but that usually, it doesn't happen because they're in the hospital and they're medicated. But that's one reason. Very good. I think Katie answered that question, and it's not to feel interrogated. And it really does. It kind of opens up that window of being able to share what that actual individual is feeling. Sometimes redirection needs to happen because things will get off course. And we have how many patients? We have a lot of patients, but not patients like ourselves, but people that we need to take care of. But we also want to get what we can so that we're able to know, is this medication working? And we'll talk about that. Is it working? How do we know it's working? Because with schizophrenia, I have never, ever, ever in 13 years dealt with somebody who is schizophrenic. This is the one diagnosis. Every other diagnosis, I may have another opinion, but this is the one that does need medication. Everything's on a spectrum, as I think I said on day one. So like myself, if this is the worst, and I'm making air quotes, by the way, if I ever say normal, I say air quotes, because what's normal? So I have ADHD. I'm like right here. So I'm functional without medication. It actually makes me more functional. So I can work somehow at, 15 to 17 hours a day. I'm not saying that's healthy. I'm just saying I can. I try not to, but I can. So any questions about that? Open-ended, we try, but sometimes that can lead to us standing there and then it's like, oh my God, how do I get out of this now? Right? So we learn these skills, and this is why we go to clinical. So hopefully your clinical instructor will help you learn how to remove yourself from situations and or put up boundaries if that happens. Because a lot of medication side effects for antipsychotics are sexual impulsivity, and they will lead to, and again, you will hear me say some very odd things, but I'm telling you now, and it's more in clinical than in theory, but you will have somebody maybe say something to you like at Crestwood, for example, which we don't go to. I think this only happened one time. Yes, it has happened once in the 2.5 years I've been at San Jose Behavioral Health, where someone took out their penis and asked one of the students to touch it. I need you to touch it to let me know if it's okay. If you're a student, it's day one. Can you imagine like, how do you respond to that? Right? It's like, help, somebody help me. Luckily, again, there are a ton of behavioral health technicians around that will be there, because I can't be on all 4 floors. There are 4 different, we'll talk about that if you're there, that will help you, and it's okay. But I will teach you on day one, because I know that your orientation was short. So I will fill in the blanks for that. So just remember that. So a lot of the time that those who are on medications that are actually being treated with schizophrenia can have those side effects of sexual impulsivity. Okay, quiz prep. You guys ready? This is important. We want to get 100%, right? Yes, or at least 4 out of 5. Anything less than that, I'm going to be emailing you. That means you weren't listening to me. And everyone's here. Oh my God, everyone is here. You guys are so amazing. Look at you guys. Seriously, you had class all day and now you're here. And you're still here, and it's 2:12. Thank you. Okay, so quiz prep. The first question I'm going to ask, and I never call on anyone, but literally this is the only way to do it to make it more interactive. So I'm not going to do that today. I will do that next time. So for example, I would say, and you don't have to answer. So I might say, Hannah, can you tell me how many hours is a 7, or I almost gave you the answer. How many hours is a 5150? And let's say Hannah was unsure. That's okay. That's totally fine. Hannah will say pass. And then I will go to the next person and say Maxwell. And let's say he says pass. And then it goes on to Nicole. And Nicole says 72 hours. So that's kind of how we will usually do it. This is day 1. So I'm going to do a mixture of that, because I want us to be comfortable with each other. This, again, is a safe place. We're here to learn, right? Oh, Chelsea, your dog is so cute. Hi, Bubba's. Oh my goodness. Hi. A+ already. Okay. You're done. You didn't have to come to class. All mine are locked away. Okay, so let's talk about a 5150, because this will come up on your quiz. And again, you will hear this over and over and over and over again, because we will become almost like a little, I don't like the word cult. I had another word. There was a word for it that someone came up with. We're like we're sold. No, I don't like the word soldier, whatever. We're a team, and we all say it together at some point. Today, that will not happen. So a 5150 is how many hours? It is a 72-hour hold. So I'm going to ask that question, and then if you guys can say that, if you can't go off of mute, that's fine. But a 5150 is how many hours?
72-hour hold.
Perfect. And a 5150 can be voluntary or it can be involuntary. And what I mean by that is, if I am somebody who has schizophrenia and I can feel myself, okay, I know we know our bodies, and we really, really should be, well, first of all, I just made a mistake. We should. Like, I would never tell a patient, you should do this. It's condescending in my opinion, especially in mental health, when you're not feeling well, most patients don't feel at their best if they're there. But if I got off track. What was I saying? Katie, help.
You're talking about how it can be voluntary or involuntary.
Thank you. So involuntary or voluntary. So if I feel my medications are quite not working and I'm like, okay, I'm having way more hallucinations than I normally have, my medication is off, I can actually walk into the emergency room and say, I am schizophrenic, I don't feel safe, and now we're going to talk about the 3 reasons why you would be put on a 5150. So there are 3 reasons you would be put on a 5150. Does anyone know those 3 reasons?
Danger to self, danger to others, and unable to take care of yourself.
Are you Mel's friend?
No, I don't know who that is.
Okay. I'm only asking because she told me, she's like, oh, some of my friends are in your class and they like you. And that's literally not only the order that I say them in, but exactly how I say it. So you are exactly, well, did you read that? Was that in the chapter? I don't even look at the chapter.
Yeah, in the video you posted, that was.
Oh, I did?
Yeah.
Oh, well, sorry, I'm teaching, it went back down to 9 classes, so it's much more manageable for me. But yes, you're exactly, thank you. That is perfect. So if I say, how many hours is a 5150? You guys would know it's 72 hours. And then my next question would be, can it be voluntary and involuntary? Yes, it can be. And what are the 3 reasons you would be put on a 5150? And I like to do it in order because I feel that helps you remember. And that is exactly, I believe Katie answered that. Am I correct? Yes.
Yes.
So it is danger to self, such as I'm saying, I'm going to slice my wrist, or I want to die. And if a patient came up to you and said, I want to die, what is the first thing you should ask that patient? Do you have a plan? This is not on the quiz, but this will come up again. You do not immediately leave that patient and run away. Sit down with the patient. Don't let the patient leave you. And if the patient leaves you, of course, go get the nurse or someone. But you want to know, do they have a plan? And can it actually be, you want to get more information. Same thing with hallucinations, just as a side note. So if somebody says they want to harm themselves, so harm means kill, or harm means cut, or whatever it may be, or is having some type of hallucination, which is one of our terminology points that we'll talk about. We'll want to find out, well, what type of hallucination? Oh, I'm hearing voices. Oh, would you mind telling me what the voices are telling you? And do you notice how my affect, and your affect is how your face is looking? So I'm not like this, like terrified, right? No, I'm very calm. I'm, relaxed, because if I become and look anxious, don't you think my patient might not trust me, or they're going to become anxious and not want to open up to me? It's kind of that same thing. So 5150 is how many hours?
72 hours.
Perfect. And what are the 3 reasons?
Harm to self, harm to others, unable to take care of yourself.
Beautiful. Oh, I like how you said unable to take care of yourself, because a lot of people get confused on what does gravely disabled mean. And literally, that is, if I ask you that, I literally would love to hear those words. Unable to take care of yourself. 2 examples: unable to take your medications as prescribed, or being homeless and not having enough food to eat. That would fit that criteria, right? Okay, so if you understand that, you just got 1 point correct on your 5-point quiz. And now we will move on to the next question. Or any questions about that? And trust me, it's going to become part of the rotation. And you will have patients that will tell you, they're very open. They tend to be I hate to say I apologize. Patients tend to be very open about that. Some maybe not, but most are very open about, oh yeah, no, I want to kill myself. I don't want to be here. I don't want to be alive. And it can be very shocking to hear the first time. So just really please watch your look in the mirror and practice. That's usually what I tell students before you go to clinical, so that when you might hear something shocking, or a patient might tell you like, I really like your ass. And again, I'm just speaking as a patient. Your face might just, what do you say to that? Or they might grab your arm and be like, ooh, Sean, your muscles. Wow, you're so, okay. First of all, they're touching you. Is that okay? It's okay to set a boundary, right? So things like that. Okay, so moving along, now we got 1 point. Let's go on to our second question is, what is a 5250?
It's extension of a 5150 up to 14 days.
Oh my God, you guys, yay. Hannah, right? Excellent. That is exactly right. So 3 days is nothing. It's nothing. I can't do anything in 3 days. It's one thing, I think I may have mentioned this in the video, if you come in drunk because you had too much to drink, and you may, you're fighting with your girlfriend, boyfriend, whatever, family member, and you might say something and you're taken in on a 5150, you might be released the next day because it was just, you were under the influence, and not just, but you were under the influence and you said something that you didn't mean. However, if there really is a psychiatric, mental health, something else underlying going on, 3 days is nothing. We need more time. Now, I would not go up to a patient and hand them the paper to say, I need you to sign this or whatever. You're going to be here 14 more days. Does anybody want to be on the psych ward? Usually there are a couple people that may want to be there because there is a warm place to sleep, or food and whatnot, but most people don't want to be there. Most people want to go home, and you're going to hear it all the time. When can I go home? People will come up to you constantly. When can I go home? When can I go home? Where's the doctor? When am I going to see the doctor? And then you defer to the nurse, right? Oh, let me find out for you. I'm happy to help you. Give me just one moment, please, right? And you don't forget them and you come back. So a 5250 allows us a little bit more time for medication to kick in, if medication is a part of that. It actually also helps to initiate the patient to want to go to groups. So we run groups, we talk more about that, but we do groups on different sorts of things, about medication, about therapy, all sorts of things. We also do therapy, as not us, but the therapists do therapy. And it actually is kind of an incentive for patients to be able to want to participate in that. So that is exactly right. So a 5250 is an extension of a 5150 for up to 14 days. It could be 4 days, 5 days, 14 days. And then there are several holds up to a year. We're only going over those 2 holds. Any questions about that?
So we just
Sorry,
need
wait.
to know that it's an extension of the 5150.
Yes, perfect. Extension.
So you said it's up to 14 days, but then you just said it could be a few days up to a year.
Yes. So there are about, I'm just going to guesstimate, like 9 different holds. So I don't know what the last hold is called, but that's up to a year. In this specific class, we only talk about the first 2 holds, which is 72 and 14 days. Not because the other ones aren't important, just because I want you to leave here with a good sense of what a hold is. But yes, you can be held up to a year, and you can actually almost be held up to a lifetime at Crestwood, which is mainly schizoaffective patients, which we'll talk about. That's on here because that's on your quiz. And those patients are, sorry, Madison. Yes, all my dogs have human names. Madison. My apologies. I think it's Amazon. I'm decorating my office, and Amazon is here every like 5 minutes. I have a problem. Am I the only one? Is it just me? COVID, like Amazon is like, I can't, it's just, oh my God, it's awful.
Amazon's here 24/7.
Right? And then I get mad when they get here, but I'm so happy when I open the box. Okay, so can relate, right? Or if you watch TikTok, and they always talk about that. Okay, so we understand. So Crestwood, for example, is a place where we have a lot of patients with schizoaffective disorder, schizophrenia, and potentially bipolar disorder who are actually living there because they're considered gravely disabled and not able to make decisions for themselves. That is one of our words that will come up next week, which is called conservatorship, where other people make decisions for you. This is not on our quiz, but I just am mentioning it. And San Jose Behavioral Health, and I don't believe any of the places you go to have anything to do with that. But Crestwood, if you ever want to look it up just for fun for 5 minutes, that is a place where, I mean, it is packed. There are so many patients there. It's one of my favorites. I don't know why. There's just a special place in my heart for it. I've been licked, like my neck. I've been touched. I mean, that's not why it's my favorite place. I should clarify that. It's just because it houses such mentally ill patients where I feel like we're really making a difference. And it's such a heartfelt, wonderful thing to be able to feel like you're actually making a difference in people in their lives where they're so vulnerable and they have nobody wants anything to do with them, but you get to be there for them. Okay, I digress. Okay, so a 5250 is an extension of a 5150 because we need some more time. We need to get more time. We'll leave it at that. So psychosis is a detachment from what?
Reality.
Did I say that on the video too?
Yeah.
Oh my God, you guys, listen. Thank you so much. Okay, so that is also something that's very important to understand. So number one, psychosis does not always go with the disorder. It doesn't always click with, most people in my experience think of schizophrenia and they think psychosis. That is true. However, you can have any one of us on here right now could have had psychosis at one point. If you don't sleep for like 5 days, you're probably going to have psychosis, 3 days even, where you're detached from reality. If you're not eating, if you just kind of what I call hit a wall, let's say you're working at Google and they're just working you to death, you can hit a wall. You have a family crisis go on, a loved one passes away, something, you can be admitted into the psych ward and had never even thought about that, or you don't even have to. I'm sorry. Seriously, like they never do this. I apologize. Maddie, come here. Come say hi to the camera. I may have locked her in her crate. But so remembering psychosis is a detachment from reality, but it does not have to go with the diagnosis. Right? Okay. Give me just 1 second. Okay. We're almost on break anyway. Okay, so we have those down. So now we are, okay, you guys already got 2 right on your test or on your quiz. Yay, easy. What does SI stand for? I don't think I talked about this. Suicidal ideation. And what does that mean? Suicidal ideation. Now, I would not walk up to a patient and say, are you having suicidal ideation today? I would say, are you having suicidal? Starts with the T.
Thoughts.
Perfect. Exactly. So thoughts. So ideation means thoughts. I would document ideation, but to the patient, I would not use that medical jargon, if you will. So SI, S is in Sam, I is in IN. So SI is suicidal ideation, and that pertains to, are you having suicidal thoughts? Any questions about that? You guys just got more than half of them right on your quiz. And I don't do this, by the way, every time. I'm only doing this time because I misinformed you, and I try to be as fair as possible. Schizoaffective, and then it's almost break time. So schizoaffective, does anybody know what that is, or have they ever heard of it? It's a newer diagnosis, probably about 10 years old. Yay, okay, good. So there's a book. What is it called? So I can't just say, okay, so-and-so, you have schizoaffective disorder. You must fit certain criteria. I can't just say you have this. So it's different than a rash. If someone had a rash on their arm, or let's say poison oak, and it was very, very obvious, and they said, oh yeah, I went hiking and I tripped and fell in poison oak. It was very, very obvious that's what it was. I know how to treat it. It's done. I don't need to look in some book and it has a code or whatever. Mental health is very different. It has a very specific book. Does anyone know what that book is called?
DSM.
Yes, very good. And that will eventually be on a quiz or a test. And by the way, I didn't mention this. I wouldn't mind Queen Amanda. Let's see your dogs. I use questions over and over again. So every single test, you will see probably about 25% of your questions are repeated because not because I'm nice, because I want you to remember them. So you're going to see all of these questions on your tests too. So, and then your next quiz, same thing, same thing, same thing. Everything it's building, and it's repetitive, not because I'm lazy. I have thousands of questions. It's because I want you to get it. And the more you see it and read it and pick that answer, and I've actually had students get it wrong, and then I blast them. Seriously. You heard the doorbell? What? Why? Okay, we're gonna get through this and then we'll take a break. I'm so sorry, you guys. Okay, and I will let you see the dogs. Oh my God. Okay, so lastly, okay, so schizoaffective. I can't just say, Katie, you're schizoaffective. And if you ever go to a psychiatrist and they say to you, after 10 minutes, you're schizoaffective, leave. Or you're depressed or this or that. We need time, right? We need history. We need information. I want to know your family history. I need to gather information, behaviors. Madison Lee, which she's this big, by the way, she's like 5 pounds. I'll give her a bone at break and she'll be fine. So schizoaffective disorder, it's really hard sometimes, and this is the last thing, and then we'll take a break. And this all goes in with schizophrenia, by the way. Everything that we've talked about, it all mixes in with exactly what our lecture is. Our actual lecture is only like 15 minutes because it's that simple with all of this other stuff. Schizoaffective, they came up, they're like, we see so many patients that have so many characteristics of bipolar disorder. And if you don't know, I know you've heard the word, you may not know exactly what those characteristics are. That's fine. You don't need to know that right now. You will. And schizophrenia. And we see so many patients and it's like, oh, are they schizophrenic? Are they bipolar? I can't quite pick which one. So they said, you know what? We're going to make a new diagnosis. And this was about 10, 11 years ago. I went to this training. I just became, I was a baby nurse, if you will. And they came up with a new diagnosis called schizoaffective disorder. So when you think of schizoaffective disorder, what I want you to think is of patients exhibiting symptoms of bipolar disorder and schizophrenia. That's it, period. So if somebody is exhibiting symptoms of bipolar disorder and schizophrenia, they're mixed together, that's considered schizoaffective. Now, is it a little bit deeper than that? Yes. Do we need to go into that? No. That'll be in your book. You'll get there someday, but wouldn't you rather get the gist? And so when you're reading a chart, you understand. Oh yeah, Amanda said something about that. Okay, now it makes sense. They have characteristics. They couldn't exactly put their finger on which one it was. They're showing both. So it's both. So what is schizoaffective disorder? They're showing symptoms of what, 2 things?
Schizophrenia and bipolar disorder.
Exactly. Oh, you know what they're doing? You know why they're barking? And good job. Thank you. Oh, we have more than one. Do we have more than one Katie? We do, huh? Okay. I was like, wait, you're Katie too. They're power washing, of course, in this exact moment. So when I come back from break, I'm going to lock myself in my room so that we block out the noise. Okay. So any questions about any of that so far? So far, you guys pretty much got every single thing right on the quiz, except for one question, which we will go over when we come back. I have 2 more terms and then we'll jump into lecture. We'll go over 4 medications and then we're done. You've done very well. Thank you for paying attention. You guys obviously watch the videos. Any questions before we take, it's 2:35, come back at like 2. Let's make someone in charge. Hold on. I'm just going to pick on someone and they're going to be in charge. Andy Lee. Oh, Andy. What's up, Andy?
Hello.
When are we coming back from break?
2:45.
All right. I'll see you guys at 2:45.
All right. See you
All right.
then.
Awesome. Thank you guys so much. I'm going to pause recording. Thank you. So play. Okay. So we left off, if I believe, at schizoaffective disorder. Is that correct?
Yeah.
And what two diagnoses are combined to make schizoaffective disorder?
Schizophrenia and bipolar disorder.
Exactly. So you're seeing certain features from both of those disorders. Very good. Okay. Then the last thing I want to go over in regards to the quiz, which also coincides with the lecture, is the 5 types of hallucinations. Of course, we have a different degree of hallucinations, but again, I want to keep this to not easy. It's not about being easy. It's more about being, sorry, those lights. Does anyone have a seizure disorder? Okay, just want to make sure. Usually they don't blink. I have them on, but they're blinking. I want to keep it for the most common of what you're actually going to read in a file or a chart. So I always go just looking at the face and like your head, usually, right? So can someone name one type of hallucination for me?
Auditory.
Auditory.
Yes.
And auditory seems to be one of, I would say, the most common for people to have, I was gonna say heard of, get it, haha, heard of or know of, which is when you are hearing things. And I want you to keep in mind that it's not always bad. It can be good too, but regardless, if I'm your patient and I'm sitting there telling you, let's say we're having a conversation and it may be pertinent or not pertinent, it may be obvious that I'm having an auditory or a visual or any type of hallucination. It may not be, it just depends. But if I were having a hallucination, even though I'm in there because I'm having psychosis, which is psychosis is what?
Disconnection from reality.
Excellent. A disconnection, detachment, whatever, same thing, perfect, from reality. Do I still maybe want to let the nurse know, even if the nurse is like, yeah, I know that. I don't care. I wouldn't want you going home and that person maybe never ever said anything about having a hallucination and hearing voices. And even if that voice is telling them, so I'm asking them, hey, so what is the first thing you want to say is what is the voice saying to you? Because I want to know what that voice is saying. I don't care if I care, but it doesn't matter if the voice is telling you you're wonderful, I love you, you're the best thing that ever happened, we're best friends. Can that change? Absolutely. It can go from that to kill yourself, slit your wrists, I hate you. So I want to make sure that that's on paper, it's documented, and we are keeping a close eye on that, as well as, don't you think that information, why are we nurses? We're gathering one part, we're gathering information, which is assessment, in order to therefore better help our patient. So if they're having hallucinations, and is a hallucination a positive or a negative symptom of schizophrenia?
Positive.
And it sounds awkward, right? To me, it sounds like it should be the other way, but you're right. It is. It's a positive symptom. So there are positive and negative symptoms. So positive would be like a hallucination, a delusion, an illusion. We will go over those words today. We're focusing on hallucination. So it's something that's added to a personality. That's how I look at it. And a negative is something that's taken away. So does anyone have an example of what a negative would be, of if someone has schizophrenia, what would be a negative symptom?
Is it like a flat affect?
Excellent. Very good, Alexis. Yes, exactly. It could be flat affect, which is usually caused by someone feeling kind of sad and it's taken away. So that's how I remember it. I really like when I can make things connected. So when something's added, like a hallucination, I'm hearing voices, I'm seeing something, we'll go over the 5, that's adding to it. So that's considered a positive. And then negative, just like Alexis said, would be a flat affect, possibly coming from feeling withdrawn, depressed, sad. And that's gonna, now why this is important is, again, method to the madness. It's gonna connect to why the medications work. And that is the very last thing that we will end on. Very good. Excellent. You guys are, wow. Damn impressive. Okay, so we have auditory. So we're hearing something. It could be good, it could be bad. What is another hallucination?
Visual.
Very good. Visual. So seeing something that is not there. And I want to make this very clear because when we go to, and we will probably next week, or when we're going through our Quizlet, we will come across the word delusion and illusion. I want to make it very clear cut what the difference is. So just really digging this into your brain, that a visual hallucination is something that someone who is not having psychosis, is not having a detachment from reality, who is, and again, I'm saying normal with quotes, please, please, please try when you're on the psych ward, not to say crazy. I do it. I'm human. I do it too, because it's kind of just part of our words. So I try to, but I try to, it can just be potentially insulting or set people off. And we want to do our very best not to do that, if at all possible. Even though it's very much a part of our vocabulary, because we're not even really thinking about the words that we're saying, but to that individual, that might really be something, if you can imagine, feeling crazy can be very, very hurtful, right? So if you are sitting here and I'm looking, let's say I'm looking at my chair over here and I see President Obama, and let's say someone else is in the room with me and does not see President Obama, and President Obama is really not here, that is considered a hallucination. What type? Visual. And that will make a lot, I mean, it makes sense, I believe, but it even makes more sense when we talk about delusions and illusions, especially because they're so similar that it's really, really important to understand the difference. But again, today we're not talking about that because that's not what we're talking about. So visual hallucination, I see a circus animal in the corner and I'm watching it and I'm at the circus. Am I at the circus? No, I'm hallucinating a giraffe in my room. That's not really there. I see it, but you guys all do not see it. That would be visual, correct? So now we know. And same thing, if I saw that, I would ask my patient, oh, what are you seeing? Because I want to be able to tell the nurse, oh, and if when you watch your video, the TED Med Talk, the young lady who, and most people who are diagnosed with schizophrenia, it's when they go to college, usually between the ages of 21 and like 29, I think I say in my other video, 23 to 26, it doesn't matter. It's usually college years when you have a lot of stress. It can change your genetic components in your brain and actually speed up you getting schizophrenia, even though you're predestined, and you get it earlier than you may have potentially were supposed to get it. You'll get it earlier because you're having all this stress happening. And this young lady who is very functional, she has schizophrenia and she's very functional. She, if you haven't watched it yet, she actually says she sees one of her hallucinations in the crowd. It's a clown, a very scary clown. And it's a huge trigger for her. However, she knows the clown's not real. She's on her medication and she's doing well. Even though she's been hospitalized, I think it was like twice within the last 4 years or something like that. So these are all things to really, really consider, especially when you're sitting there talking to your patient, not knowing that they could be hearing in their left ear, this person wants to kill you. They hate you. They're just here to get information from the CIA. When you don't know that's happening. But if you have an understanding that might be happening, it would make more sense to you why they may be like, get away from me, I don't want to talk to you, rather than you taking it personal. So these are why I really try to kind of not warn you, but give you the most information I can so that you understand what might be going on in their minds when you're talking to them. It's not you, it's just, it's unfortunately the diagnosis that's happening. It's kind of like you being in a bad mood if you don't sleep for 24 hours and you're just kind of pissy. It's a little bit like that, but way unfortunately worse. Okay, so we have auditory, we have visual. What is this? What's it called? It starts with a G. Not smell, but let's use the real word.
It starts with a G.
Yes.
Gustatory.
Who said that?
Oh, Andy.
Andy, did you say it again?
Gustatory?
Gustatory, very good. Yes, a lot of people no, yes, you can say smell, but in a chart usually we'll say gustatory. That's the actual term for it. Very good. So we have auditory, visual, gustatory. So someone might say, wow, I smell I can never think of something for this one.
Isn't gustatory taste and
Oh,
olfactory?
sorry. Yes, you're right. I'm so sorry. Yes. See, I'm human. I make mistakes too. Thank you. Yes. Smell. Andy, you're wrong. -1.
My
1
bad.
point.
I was just testing Katie. I know she
See,
does it.
I thought you were. We planned this
Yeah,
beforehand.
we were working it
This
out,
was
right?
all an act. Andy and I had this down. And very good. And please call me out. I'm human. Okay. I'm just like everyone else. We all make mistakes, even though I've been doing this forever. So yes, absolutely right. But you got the word right too, right? So we're all a team. We did it. So smell. So we have auditory, visual, smell, gustatory, and then what? What is this? Starts with a T.
Tactile.
Very, very good. Oh, my dad works at Crest. Ooh, that's Mitzi. That's very interesting. Talk to your dad about that, and bring that to clinical, because Crestwood is definitely an interesting place. So yes, so we have tactile, which means that we feel things. Can you imagine feeling like you have something on you that's not on you? I mean, any of those would freak me out. Any of those hallucinations, right? So one more time, and I like, again, I like to do them in order. So I always start with this. So ears are what?
Auditory.
Auditory.
Visual. Olfactory.
Oh, I like that. See, nursing terms, very good, Katie. Andy, what is this?
Oh, gustatory?
Gustatory, and then
Tactile.
tactile. Perfect. So we have now reviewed the entire quiz. So if you understood all of that, what we talked about, 5150, 5250, psychosis, SI, schizoaffective, and the 5 types of hallucinations, you will get a 5 out of 5 on your quiz. Exactly what I said, and we're recording. If you feel like you need to watch it again, I don't think you will need to, but I will actually after this. So what I do is I will upload it to within 24 hours. 36, but really usually 24. I will upload it to at the bottom of our box for today. It'll say video lecture from today. You can rewatch any part of the video that you would like. Very well done. Any questions about those, any of those terms before we do our lecture, which is really pretty short actually on schizophrenia, because we just covered a bunch of it with these terms. Did you notice some, like 3 people just signed off now that they got this stuff for the quiz?
I think they got disconnected.
I know, I'm just kidding.
Oh, okay.
Andy,
mind.
you're so cute.
I take everything so literally.
When they sign back on and be like, what were you doing? Busy? Any questions about any of that? You guys good? You did very well. And thank you. It shows that you either read, just knew it, or you watched my video. So I really appreciate that, because I do put time into it and I really want you to learn. So excellent job. Here they are. Perfect. Hannah was right. I like that. Looking at the good in people, right? Okay. So now that we have our quiz prep down, let's talk about schizophrenia. So we've already talked about schizophrenia as far as age, and the most common. Now remember, there's always a spectrum on everything. So there are children that do, and they are, they may not be specifically diagnosed with schizophrenia, but they do have strong signs of schizophrenia. But again, we're looking at the bigger picture, because we have one brain, we have so much to learn. Let's really focus on what is the most common. So the most common age is college age. Now, when we say that, some people go to college at different ages. I'm talking about the college years after high school. So usually anywhere from like 21 to 26-ish up to 29. And that is not on a test. That's not on a quiz. That's just for you to understand. You're breaking up with me? Katie, don't break up with me. Can you guys hear me?
Oh, Katie left because she was having bad connection and then she came back on.
Okay, thank you.
Yeah.
God, you guys know everything. Literally just listen to Chambers. Yep. Is smell olfactory? Yes, good. Isn't smell olfactory? Perfect. Yep, you guys are so good. Okay. So age-wise, and the reason why I bring that up also is because in the video that you're going to watch on the TED Med Talk with the young lady, she talks about how she was in college, and a lot of the time it can be very, very traumatic. And I really want you to understand this, please, 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 please. Almost if you get nothing else from this, if you can please try to understand this, because I've seen it firsthand. People, and I'm not trying to say that psychiatric, I don't even like that word, psychiatric ward, but the psychiatric unit, whatever you want to call it, whether it's inpatient or outpatient. If you don't know the difference, you will. We do have a lecture on that. I work in outpatient. I do not work in inpatient. So inpatient it's more acute. So that would be more like ICU. I work in outpatient when a patient is now free to leave the hospital and then they come back. I've worked both. I've worked all of them, but right now I'm working, I teach. I just rolled my eyes. I didn't mean that in a negative way. I teach mainly a lot now, but I do work outpatient at El Camino Hospital. And the difference with her is that she has there's a very negative stigma with going to the hospital. She's afraid of the hospital because what happened with her, if you didn't watch, and this happens with a lot of people. And again, I'm not saying that cops are bad or firemen are bad or anyone's bad. I'm just making a statement of why people tend to be so afraid of going to the hospital is because of the way it goes down. So we hear the word schizophrenia. There is a stigma with that, or can be a stigma with that. And it's not because you're a bad person. It might be just because you're not really familiar with it. And which is one reason why I decided to go into teaching, because I really wanted to give an outlook on, hey, it's not always this way, it's not always that way. And even if it is somebody that's on a street corner who may have alcoholism as a secondary diagnosis and is screaming at cars and this and that, do you think anybody wants that for their life? Do you think anybody says, oh, I want to be homeless and I want this or I want that? No, there's something actually going on. So I'm going to say one word to you: neurotransmitter. Think of the brain. So we know that our brain, every part of our brain does something specific. I'm going to give you the most simplistic thing that I think. I'm going to take you back to high school. Serotonin. I think all of us know what serotonin is, right? Serotonin is something that, now it does not cause euphoria. We will talk about this next week. However, it does cause, and yes, I go like this and you will know why later, it causes a sense of well-being. So if our serotonin is working correctly in our body and in our brain, well, mainly in our brain, we'll talk more about that later. There's a lot of it in another part of our body, but it helps us to feel well-being. Just like me being able to move my arms even like this has to do with dopamine. So what are some other neurotransmitters? We have dopamine, serotonin, norepinephrine, glutamate, but we're talking about schizophrenia. What is the number one neurotransmitter? Now, of course, there's more than one, but again, we're not leaving here masters of science of, psychiatry. What is the number one neurotransmitter that has to do with schizophrenia?
Dopamine.
Excellent. Yes, that might actually be on your quiz too. So dopamine, I'm looking at my paper just to make sure I didn't write it over there, but it might be. I know it's on a test. It's on something. So dopamine, exactly. And now I want you to remember something very, very important, please. Depending on where a neurotransmitter is in your brain, that can change how and what it does. So, for example, if dopamine is working in the frontal part of your brain, that has to do with impulsivity, judgment. You don't have to write this down. This is just an example. All neurotransmitters have more than one purpose, depending on where they are in the brain. So dopamine in the frontal lobe, again, impulsivity, which has to do with ADHD, which certain people have ADHD, so they may not have their dopamine working properly in their frontal lobe, has to do with making good decisions, critical thinking. If it has to do with dopamine in the substantia nigra, which is in the middle of the brain, that has to do with Parkinson's. And we all learned about Parkinson's, right? Unfortunately, what happens with Parkinson's? Do we have too much dopamine or too little? We have a shrinkage of receptors. So we're not able to get enough dopamine. And when we don't have enough dopamine, what did I just say about my arms being able to move like this? What do we see? We see that shuffling gait. Remember? With Parkinson's patients, it's really sad when we see tongue rolling. And this is all very important. This is going to come back. And they connect, it actually does connect to schizophrenia, because we have something called Parkinsonian, which happens, it's a side effect from the medication. So this is why I'm talking about it. My phone's ringing, just making sure it's not one of you. Nope, it's my school. They want money. I did not have time to pay today. So Parkinson's has to do with lack of dopamine receptors. So if we take too much dopamine away, we're going to see certain symptoms. So think of Parkinson's, tongue rolling. Remember the pill rolling in the fingers? The shuffling gait, possibly drooling, tremors, very uncomfortable. And why does that happen? Because they don't have enough dopamine, specifically in the middle part of the brain. Okay. Now, with all of that said, and I'm going to make it all come back around. Now let's talk about schizophrenia. Yes, it has to do with serotonin. Yes, it has to do with more than one neurotransmitter. But as we mentioned earlier, it mainly has to do with dopamine. Is it too much or too little? And it's okay if you don't know. It's too much. So what happens is somebody who is suffering with schizophrenia has too much dopamine. And when you have too much dopamine, think too much and think the plus sign. Plus sign means add, right? So you have dopamine, which is going to cause positive symptoms, correct? And what are positive symptoms? Hallucinations, delusions, or adding symptoms to your personality, right? So you have too much dopamine. So in order to help somebody with schizophrenia, what do you think we need to do with the dopamine? Do we need to increase it or lower it?
Lower.
Exactly. We need to lower that. And again, for this specific, and I'm not saying, and I'm very open and I never say it must be this, it must be that, we must do this, we must do that. But with schizophrenia, I have never, ever, ever treated a patient that has been treated who has not been on medication. This is the one that unless, and please tell me if you've ever seen it, then that's okay. Please, I'm just telling you, that needs medication, antipsychotics. So what do you think antipsychotics do? If I gave Andy, I'm just going to use Andy because I think he would be okay with it. And if you're not, you can tell me not no, but you're on my screen, so I'm going to use you. Let's say Andy is exhibiting positive symptoms. He's been diagnosed with schizophrenia. And what book did I use to diagnose him?
DSM-5.
You are correct. Absolutely. Because he met the criteria. So I diagnosed him with that. That does not mean that his life is over. No, not at all. That does not mean that. We can manage that. However, it may take some time. and it's not easy. What can I do for him? I can put him on antipsychotics. We have older antipsychotics, as we talked about earlier, and then we have newer antipsychotics, which are much, I'm not saying one's bad and one's good, but they have much, much less side effects, which really, really are, I mean, who wants to have side effects, right? So if you have less side effects, don't you feel you might be more prone to take them? Yes. So what do you think is going to happen if I give Andy an antipsychotic? What is that going to do to his dopamine? It specifically goes to his dopamine receptors. And what is it going to do? Is it going to lower them or raise them? Say it,
It's gonna
Andy.
lower them.
Perfect, Hannah. Yes, it's going to lower them. And therefore, what is it going to do to his positive symptoms? Hallucinations, delusions, hallucination, all of these things that we're seeing, his behavior. How, if it works, how should his behavior look?
Would be reduced, lowered too.
It would look better, right? We would hope that you would have, you still might have some hallucinations, you might have some symptoms. I mean, nothing's perfect, but wouldn't you rather have just maybe a few voices here and there, or some things happen rather than it happening constantly? Because then you can function in life, get a job, maybe have, you know, a family, and live a life and have quality of life, right? So it's a simple equation. Schizophrenia equals too much dopamine. Too much dopamine equals too many positive symptoms. We must give an antipsychotic. We give an antipsychotic, and what does that do? It lowers dopamine. Does that all make sense? Any questions about that? Because now we're going to go to the biggest and one of the most important parts of this, other than the stigma and quality of life. And that has to do with what happens if I give, I'm not a magician. So in a year, I'll be able to prescribe medication if I pass my test, which I will. So in a year, okay, I'm still going to use Andy here. And let's say I put him on a medication, and now I'm going to flip my book over, and I'm going to give you two names, just two names. This is not on a quiz that's coming up anytime soon. You may see it on your quiz, may or may not be the answer. Probably not. Because I'm going to tell you what the, we're missing one that's on the quiz. So Abilify, 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 and Zyprexa, Zyprexa. Those are two antipsychotics, just for fun. Just to start it. You're going to hear them again and again and again and again and again and again and again. And by the end, you're going to be like, oh my God, shut up. I know what they are, but they're going to be so drilled. So Abilify and Zyprexa. Those are both newer antipsychotics. I'm not magic. I don't know what's going to work for Andy. I don't know exactly what dose. What do you think is going to happen if I put him on a dose and let's say it's too high for him? What's going to happen to his dopamine? Is it going to go too high or too low? He's schizophrenic.
Too low.
Very, very good. Exactly. It's going to go too low. So what did I mention earlier about those who have Parkinson's? Do they have too little dopamine or too much?
Too little.
So how do you think Andy might present?
Kind of like he has Parkinson's.
Oh my
Like
God.
he would have the
Yes.
shuffling gait, and would he have like hand tremors too? Or
Tremors, the pill roll, the tongue. Excellent. Very, very good. Perfect. Exactly.
Hey, I
what
mean, I
happened.
have a quick question.
Please. Yes.
Is this would this be kind of like talking about saying that when you have to prescribe a patient, it takes hold on, let me get my thought together. Is this why okay, so is this why when you have certain patients that you give these medications to, that they end up going off the medication because they don't like the way that it feels, and it's almost too early, quote unquote, for them to continue the treatment that the doctor prescribed?
Excellent. That is beautifully said. And let me tell you why. So this can happen with any patient, depression, anxiety, bipolar disorder. However, unfortunately, with this population with schizophrenia, and this is, I would say, evident. I mean, I can't give you the percentage, but definitely evidence-based. And thank you for bringing this up, John, is that if you have a patient with schizophrenia who has psychosis, which would be a detachment from reality, and a lot of the time is very paranoid, or thinking this pill is being put into my body so they can watch me and track me, and so keep in mind, please, that I don't want to say most, a wide majority of those who are diagnosed with schizophrenia are not medication compliant. You're absolutely right. And this is why, is because it does take time to work, and it takes one thing I hate and I feel is so valuable in the work that I do, and I really, really try. So I work, my passion, I mean, obviously it's mental health, but is addiction. That's like that's what I specialize in. But all of this, of course, goes with it. I validate patients so much on feeling like a lab rat. Wouldn't you feel like a lab rat, John? If I was like, well, hey, I'm just going to try this and let's try that and let's try this. Because I can't just look at your arm and be like, hey, you got a cut on your arm. Let's clean it up. It's in your brain. I have to look at your behavior. It takes time, and it can be so frustrating. So I feel at times, as unfortunately, if a patient is delusional at the time or having these hallucinations, that can be very difficult to deal with. But hopefully we have things like injections that we can give patients that last for 30 days. So usually we'll do that, even unfortunately, if it's against their will, and we'll talk more about that. It's under a conservatorship, which that's, I believe, next week, where the medications in your body, you can't do anything about it. It starts working, and then the brain starts doing hopefully what it should do. And hopefully that person that has schizophrenia will be able to think a little bit more clearly and make better, or want to participate. That's the hope. Did they answer your question, John?
Yeah, no, that's what I kind of figured. I just wanted to make sure that my just thought was relatively in the ballpark.
Are you 100%? Absolutely. Thank you. And that's very important too, because that might be a question that asks, do all patients with schizophrenia, for example, no one's in a box. Do you think everybody with alcoholism acts and is the same? No. Do you think everybody that has anxiety acts the same? No. Do you think every patient with schizophrenia acts the same? I'm going to let you answer, because that might be a quiz question.
No.
Exactly. So please, if you would, I really hope that nobody is ever put in a box, because would you want to be put in a box? Like, oh, okay, so you're blonde, so that must mean you're a bimbo and dumb, right? I'm not saying that to anyone on here. I'm just saying in general, like, we hear, or, oh, that person has tattoos, they must not be smart. Or I get it all the time. I'm the youngest person on the faculty at every school I work for. I am the most out there, whatever. But I'm not going to change for anybody. I am myself. I'm me. We are who we are. And I mean, as long as we're hopefully acting within some realm of professionalism, we're going to stay where we are. I'm the only one that, paints her nails. I'm the only, whatever it may be. But we don't want to be put in that box. I'm also a doctorate student with a 4.0. I'm a director at one of my schools. I'm this, I'm that. Same with you guys, right? I mean, we don't want to be put in that box. And I really, really, really hope when you're in clinical, you would, and I don't think any of you would do the same thing, but subconsciously we might do that. Right? We might think, oh, schizophrenia, crazy. I'm scared. Oh my God, they're going to hurt me. No, it doesn't mean that. It could be like the best conversation you've ever had, and you'll leave that day. I literally just got chills, like tingling, because you feel like you really helped someone. It's such a magical feeling. I can't wait for you guys to hopefully have even just one good day, because you never know. One day might be good, and one day is like, oh my God, I'm never going back. Like, this was so scary. You never know. So very good. Okay. Okay. So I think So excellent question. So John, you actually answered one of the things that I wrote down here, which has to do with unfortunately the not taking of the medication. That is something very popular in the schizophrenic community and population, being afraid to take the medication, which is very, very, very sad. We're getting better at it though. So we talked about, hopefully, can you guys hear me? It says I'm unstable. Not me, but well, who knows? My computer. Nicole, can you hear me? Because I can see you.
Yeah, I can hear you.
Okay, perfect. Okay, so a newer, we talked about Abilify and Zyprexa. So now we're talking about Andy. So we talked about him and we said that, I believe Hannah answered the question and she said, unfortunately, if I give him too much, and then I come back and I'm looking at him a couple days later, I'm noticing that he's having tremors, tongue rolling, and now we have to outweigh the good with the bad. So how bad is it and how livable is it? So if it's pretty uncomfortable and my patient's not looking comfortable, I can do one of two things. I can either titrate the dose, and titration meaning either go up or go down. In this case, what I want to lower, let's say he's on Zyprexa, which is one of our newer antipsychotics. Would I want to lower it or increase it? If he's having Parkinsonian, that's what we call it. Technically, the umbrella term is tardive dyskinesia, but I call it Parkinsonian because it has straight to do with, and you guys will watch the video, and this will make sense. Again, it'll all come together if you haven't watched it yet. He's having Parkinsonian. He came to me, his tongue is kind of rolling around. And if you've ever seen it, it looks so uncomfortable. I just feel so, it crushes me. And he's having pretty significant tremors. And he's telling me, I don't like this. I'm uncomfortable. What can we do? And he's in the hospital. So he's not leaving. What can I do for him? What should I do with the medication? Should I increase it or lower it?
Lower it.
Very good. And that was Devin. Yeah, Devin. So you go by something else too. You have like 4 names, right? I did your paperwork.
No, just Devin.
Okay, Devin, thank you. Sorry, I did so much paperwork. I'm like, I was trying to keep everything straight. So let's say that, so we could do that, or we could do something else. There's a medication, and I kind of call it a Band-Aid, even though I'm not meaning that in a negative way. What is a medication? Does anyone know that you can give that can kind of offset those symptoms as well? So we can either lower it or do what? Give them what medication?
Would you want to give them levodopa, or would that like increase our dopamine too much?
So close. So you are so on the right track. So, and many people say that, so I love it. So, because you're thinking Parkinson's, right? So when you give a medication for schizophrenia in general, that is a cholinergic. So antipsychotics are cholinergics. So I'm going to want to give an anticholinergic. It's called Cogentin. Has anyone ever heard of that? Cogentin? It's also called I always say it wrong, benzotropine. No, that's right, benzotropine. But I don't like to use that word, and I'll tell you why, because I feel it's too close to a benzo and it can get confused. So I like the word Cogentin. So as the provider, I can make the decision. Do I want to add in Cogentin or do I want to lower the dose? So if somebody's having Parkinsonian or tardive dyskinesia, it can be said either way. I will usually say Parkinsonian because, again, why? I like to make the connection because it makes sense to me. I can either do what? Lower the dose or give them Cogentin. And then hopefully after a couple of weeks, we'll get on some sort of a regimen. And it's not just about having an antipsychotic. So now let's say we've got the antipsychotic down, hallucinations are lowered, functioning is starting to happen. You can see an improvement. It's oh my God, it's one of the best. It is just amazing and one of the best feelings. But a lot of the time when we have mental health diagnoses, it's not just one thing, right? We may have other things going on. So do you believe if you are schizophrenic, do you think maybe you have anxiety too? Or you might be depressed. I might be depressed if my family doesn't want to talk to me, or I'm lonely and nobody wants to be around me. That might make me depressed. So your patient also might be on another medication too. They might be on some, I'm not just, I guess my whole point of saying that is it's not like the answer to everything. Here's the antipsychotic, you're all better, yay. No, here's the antipsychotic. Hopefully that gets you to a place where you can focus, and then you can maybe do therapy. Do you think you can do therapy? Let's say you're having a panic attack. So John, you're on my screen. Let's say you're having a panic attack. Do you think I can call you into therapy and like talk to you, and I'm going to like be able to really maybe get you down from your panic attack, but we're not going to be able to do therapy during a panic attack. I mean, that would, right? But if I'm able to get my schizophrenic patient to a point where I can be able to talk to them and lower the voices in their head, don't you think therapy may be helpful? It may be helpful. Again, everyone's different. We're not in a box. So I kind of want to put that out there. Any questions so far? We're kind of wrapping up actually, which is odd because I never wrap up early. Is this making sense? Please let me know, because I'm not using any, today's just me talking. But do you see the connection, how we're doing that? And every week we do the same thing and we build upon each other. And it's just like this really cool, I can't explain it, that happens. Okay. So newer medications for antipsychotic are what? Give me the A one first. What is it called?
Abilify?
Very good. The other one?
Zyprexa?
Correct. And there's several of them. We're just talking about 2 today. I don't want to overwhelm you. We're learning so much, right? Now, the older ones that I mentioned earlier, one is called Seroquel. And that is spelled, you'd think I would know by now, right? Seroquel. Seroquel. And another one might be Haldol. And again, these are just examples for you. So, and we're going to keep building upon them because we do medication madness. So by the time you're done with this class, you'll know a lot of meds and hopefully be able to recognize at least half of them you'll retain. Okay. So newer ones are Abilify, Zyprexa, older Seroquel, and Haldol. Now, can somebody tell me, please, so what does affect mean? And I'll go like this, always.
It's like kind of the way they present themselves, like with their facial features.
Perfect, exactly. And what I find, I mean, they're both important. How you're presenting yourself, your body language. Are your hands in your pocket? Are you standing like this? If you're standing like this, don't you think that's kind of like, that could be scary to somebody who's having a hallucination that thinks you want to hurt them, or they may think you don't care about them, or just in general, in the hospital, just somebody who's going to have their appendectomy. It's rude, right? To stand there like this, because we know what this means. Usually it's like closed body language. So your affect, exactly what Andy just said, yours is important too. So, and it's so much to remember because it's hard, especially with the mask too now. So we have a mask on. You can tell, what's that lady, Tyra Banks, you smize or whatever with your eyes. I don't know if you guys ever watched that show. I don't watch it anymore, but you can tell when someone's smiling usually at you because your eyes, or, you say hello and they may say, fuck you. Okay. You don't have to say anything back. It will happen to at least 2 of you. I promise. Poor Andy will probably be one of them for no reason, just because you're on my screen. So I'm picking on you. But it happens, but that's your affect. So we really want to pay attention to our body language. Example, I was at San Jose Behavioral Health, which we'll talk about more. I was on the, what's it called? It's a unit that, oh, seriously, Amanda. Anyway, it's a unit with all men. It's considered the most dangerous unit. It's my favorite unit, of course. Not because it's all men, just because it's the most dangerous. And I learned too, right? And if you are going to San Jose Behavioral Health, I will just say this right now, if you're not comfortable in that unit, and I'll tell you more about it when we're there, I've had students ask not to go on it because you don't have to tell me why. They may have trauma because there are sexual predators that are on that unit. There are gang members. I mentioned that a little bit. And, I've had patients, I forgot now what I was even going to say, what happened. It can just get a little bit intense. Let's just put it that way. And we want to be able to, I'm not going to go in there, walking up, acting like I'm all that. And usually a lot of them want to, that's what I was going to say. They love my tattoos. That's like the first thing they see. That's one of the reasons I love going there, because it's so hot. I hate wearing that stupid lab coat. Oh, I'm recording. But they let me, I asked the DON. It's so hot in there. I can't run between 4 units and I'm like dying, sweating. And they want to come up and see him. They want to touch him. And you have to learn how to do that. And I will teach you that about a nice way to say it. So if someone says, are you married? What are you comfortable sharing? What should you be comfortable sharing? What should you there's a lot of gray area in there. And I want you to feel as comfortable as possible. So we will go over that if you're with me. Ranjit, all of them will. We have some really good staff members. We have a really good crew this time, in my personal opinion. Okay, so we have talked about schizophrenia, what causes it in the brain, the behaviors that we're seeing, a couple of the medications that can be used to help with it, how the medications work, why we're seeing the behavior. Any questions about that? And we're about to wrap it up. We talked about affect, the book to diagnose. We talked about neurotransmitter. The last thing I have on here is conservatorship, and I'm just going to tell you, for someone that is conserved, I'm sure 50% of you probably already know this, but it's somebody that is, and this is how I like us to say it again, because we're all hopefully going to say it at the same time at some point, is somebody that's unable to make their own sound decision. So that's what that means. So somebody perhaps that is schizophrenic who is, thinking that the CIA is after them. So one thing you're always, okay, please listen to this. If you're on a mental health unit, avoid these 3 topics: the president, the CIA, or any type of police. Okay, please. I was on the all men's unit. Did I tell you about that? And someone came up to me and said, I am Jesus. And then someone else came up to me and said, I'm the devil. Did I tell you guys about that? And
No, you told us.
yeah. So thank you. I will not bore you with that again, but I'm like, oh my God, seriously, the first day. Luckily it was handled well. But he got to do what he got to do. And it just happens. You never know what's going to happen. I think that's why I like it so much. It's never the same. It's always different. So being conserved, and we'll talk more about that later. I just want to make sure that you guys are all prepared. So I will upload the lecture. Please understand the stigma. I think I don't need to go much more into that. There is so much stigma against mental health in general, especially schizophrenia and addiction. I think those two, and bipolar, because it's all in the media now because of Britney Spears, and it's like people don't understand it, but you guys will. Treatment can help. There is treatment and there's hope. We talked about that. Okay, my last question. What does it mean if a medication is used off-label?
Used for something.
Devin, did you say that? Because I know you said it right, but it broke up.
You want me to say it again?
Please.
I said it's used for something other than what it's actually for.
Excellent. Perfect. Perfect. Exactly. So when a medication is used off label, exactly like Devin just said, it's a medication that is intended for one thing, but they're using it for another. Easiest example of that, and we will talk about way more of this as we go, because a lot of mental health medications are actually used off label. But I'm going to give you what I think is the most simplistic just for now, because we've gone over so much, is Benadryl. So it could be either prescribed or not prescribed, by the way, an off-label medication. So what is Benadryl's classification? It's actually an
Histamine.
histamine. Exactly. Very good. So Benadryl is an antihistamine. However, what can we use it off label for?
To sleep.
I feel like a mime. Yes. to sleep. Exactly. Exactly. So they notice, wow, this antihistamine is making people tired. So we could use it off label and help people sleep. That's all I'm going to say about it. I'm going to go way more into depth about off label, but I just wanted to make sure that that was understood, because a lot of mental health medications are used off label with schizophrenia as well. So I'm just going to do a quick look before I ask for questions, that I made sure that you got everything you need for your quiz, that you got everything that you need as we build. I'm just taking a quick look. We're doing that next time. Christine, would you mind taking 1 minute and telling us about your toilet paper roll experience and what I mean by that? If you're there. Everyone's like, what are you talking about? Weirdo. Toilet paper experience? No, Christine? Did she leave? Did she leave us? She had a job. Okay, well, she was going to tell us she did the toilet paper roll assignment, so you'll see, but she had said it was really interesting. Yeah, we went, wow, I cannot believe, am I early? This has never happened in my life. Okay, I am. So I'm going to ask you something in 45 seconds. And I need more than one person to respond. So if you're able to, and you're not somewhere where you can't like talk, when you have schizophrenia, do you have too much dopamine or too little?
Too much.
Too much.
Very good. And what type of medication is always given to somebody who has schizophrenia?
Antipsychotics.
Very good. And how does an antipsychotic work? It lowers what?
Dopamine.
Dopamine. Exactly. If you lower dopamine too much, what can you experience? What is it called?
Parkinsonia.
God, you guys are, thank you for listening. Very, very good. How many hours is a 5150?
72.
72.
And what is psychosis?
A detachment from reality.
Excellent. And what is schizoaffective? What two disorders put together?
Bipolar and schizophrenia.
Oh my God, I don't even need to be here. And the last thing that we're going to do just for fun. Oh, what is the medication called that we can use for Parkinsonian?
Cogentin?
Excellent. Very good. Very good. All right. And the 5 hallucinations.
What is it? Can you repeat the medication?
No, absolutely not. Yes, of course. Cogentin. Did you get it? Oh, he's freezing. So Drew, come back to us.
Yeah, I got it. I got
Okay.
it.
I'm actually going to type into the thing too. I typed it. Wait, I just gave it to Mitzi only, I think. Yes, I did. I'm sorry. But you got it, right? But I'm still typing it to everyone. Okay, Cogentin. And Zyprexa, that's a newer one, right? A newer what?
Antipsychotic.
Yep. And what is the Abilify?
Antipsychotic.
And it's a newer one?
Yes.
And it's Seroquel, and I'm typing it older or newer?
Older.
Old. And is Haldol a newer or older?
Older.
Excellent. So you might see more side effects with Seroquel and Haldol, right?
Yes.
Yes. Doesn't mean you won't with Zyprexa and Abilify, but they're newer, so you're less likely. All right, the last thing we're going to do, the 5 hallucinations. I'm going to point to them. What is this?
Auditory,
Auditory,
Visual.
visual,
olfactory,
Gustatory.
respiratory, tactile.
Tactile.
Excellent. So that is kind of the beginning. And now we just build from that. So we will build on our terminology like 5150, 5250, psychosis, SI, all of that type of Parkinsonian. And then we'll build on the medications like Abilify, other off-label medications. Why does Benadryl make you tired? But Allegra doesn't. And we'll just keep building and building and building. So every time that we have lecture, we will more than likely build upon that. You're prepared for your quiz, which is next week. Do you guys want me to open it now?
Yes.
I'm just going to open it now and I'll keep it open for a week. I don't care. So if you want to take it, you can take it. That sound good?
Yes.
Devin said yes, so we're doing it. You don't have to take it though, you guys. Don't, everyone's like, what? No, you don't have to take it. So I'm going to open it. So if you want to take it, you're more than welcome to. If you don't want to, you have a week. And again, I mean, it's 3:44. It's Friday. You guys are probably burnt. Get a snack, go stretch, go to bed if you can, call in sick to work. One time I told someone on a Friday night, just real quick, I was like, I don't want to go on this date. And they're like, tell me your dog died. I'm like, what? Why would you say that? And like, if you know me, like I am like, I love my dogs. I think I told you I have a Boston, a pug, and 2 Chihuahuas. Like they're like my life. And tell me your dog died. I think 2 people said that at the same time. I'm like, yeah, okay. Evil. So any questions about anything before I let you go live your life? Oh, Andy, are you okay? You look disturbed. He's like, how can anyone say
I'm okay.
that? All right. Well, if you guys, anybody have any questions, comments about anything?
I had a really quick question about 5250s.
Yeah.
Does the patient have to consent to it, or could it be like a doctor like requiring it?
Excellent question. No, the patient does not have to consent to it. It's the physician, NP or PA saying, we do not feel that you are able to leave. So you can actually go in voluntarily and be put on an involuntary 5150 or 5250. Very good question. Excellent. Thank you for asking. Very good. Any other questions that I can answer?
Max wants you to show the dogs, your dogs.
Max says?
I think we all do.
Okay, fine. All right.
Show us the puppies.
Here we go. It's going to be chaotic. Oh God, I hope they're not doing anything weird. They probably are. Okay. Okay. Oh, well, hello there, Madison. Okay, here's Maddie Bear. Madison, come here. Come here. Mama, come here. Okay, so this is Madison. Can you guys see? Say hi, Maddie. So this is the 5-pounder that makes all the noise. Can you guys see her? So she's blood related to her brother, who's probably in bed, scared to death because they're power washing. Jacob, what are you doing? It's dark in here. Come here, Bubba. Come here. Come here. Hurry up. They want to go. Oh my God, he's scared to death. I just hit him in the head. So this is Jacob. He looks much older. They're the same age, but he's got a lot of anxiety. He's on gabapentin actually for his anxiety. And the other 2 are in the bathroom. They're the really, really cute ones. Don't tell anyone that I said that. You guys say hi. This is Violet. She's a Boston. Say hi, Mama. Say hi. Say hi. Okay, and then this is may or may not be my favorite. Come here, Tyler. My pug. Oh, my baby. This is Tyler. my life and my soul, and he's a baby. So when he gets mad, he throws fits and he throws himself on the ground like a baby and like a toddler. So these are my babies that I have a nanny and a babysitter for because I have no significant other. No, you cannot come out. Not yet. They do not get along with the other two, so I have to keep them separated. That's what happens when you get divorced. So try not to do that. That was my cardio for the day. Yeah, so I hope you guys enjoyed this a little bit. I hope this wasn't torturous and you learned. And again, we're going to keep going over and over and over it again, and it's going to be in your head. And I hope clinical. Oh, so if you're in clinical with me, please do not forget San Jose Behavioral Health on Wednesday at 3. If you're with Ranjit, it's Thursday at 3. Even though it says 2, it's 3, okay? And we'll meet out in front, please. Kind of like we did for our, whatever that thing was, orientation.
And review section 4, right? Not section 10.
You are correct. Yes. So we're going to do, I probably shouldn't have recorded the dog thing, but whatever. It's not like I did anything weird. Except my dog's drinking my coffee. Okay, Jacob, don't do that.
Amanda,
Yes.
I had a quick question. So we were actually confused because it seems like there's 2 sections scheduled with Ranjit for Thursday at 3.
Oh, of course.
So I'm not sure like who's going.
So he hasn't told you?
Not our section anyway.
Oh my God, Ranjit. Okay, so I'm going to call him after this and I'm going to tell him to post an announcement immediately of who's going on Thursday. So what will happen is some teachers do like every other. I don't like doing it like that because I think it gets confusing. You don't get enough consistency. So group 4 will go for 5 weeks and then boom, group 10 will go for 5 weeks for me. So I will call Ranjit right now and have him post it for you.
Thank you.
Of course. And if you guys ever can't, like if you're nervous or anxious or something about like Ranjit not communicating, you have my number. Please ask me because I'm, like I said, I get paid to babysit him. Oh shoot, I shouldn't have recorded that either. I'm just going to stop recording. But it's true, I do. A lot, apparently, because I got paid yesterday. I was like, what? Oh God, I am still recording. You guys, help.